Hello, everybody. I'm Dr. Wells Stewart, orthopedic surgeon with OrthoVirginia here in Richmond, Virginia, specializing in hip and knee replacement. I want to welcome everybody out today to our April 2025 Facebook Live talk covering hip and knee replacement this month. This has been a good series that we've done for patients, kind of give informative talks about different topics in orthopedics, and generally been well received. I hope you get something out of them. So last year I gave a talk on hip and knee replacement that kind of focused on the implants that we put in and the technologies we use to put them in. Today, I wanted to focus on kind of the other side of surgery, not the metal and the bones, but kind of the soft tissue and the approach which we take as surgeons to get down to the bone to do that surgery. And so I kind of want to talk about how that process has evolved over the years, what's it looked like, and how do we get to a time now where we kind of do muscle sparing hip and knee replacement, and why I kind of feel like that's kind of the most soft tissue friendly way to do surgery. So our kind of game plan for today, we'll kind of run through briefly the basics of hip and knee replacement. I'm assuming if you're watching this video today, you've already got some joints that hurt. You're kind of already thinking along those lines. So we're not going to go into the whole kind of pre-op workup stuff. We're going to kind of go straight to the surgery part. From that point, we'll kind of dive off and go down really what I consider the evolution of the surgical approach to hip replacement, and where we started from the days of John Charnley down to modern direct anterior total hip replacement. From there, we'll kind of move to the knee and talk about the evolution that's occurred there. And then finally, we'll kind of go over some advantages, and I'll show some patient videos to kind of show what's possible in terms of early quick recovery by muscle sparing techniques. So hip replacement is the definitive treatment for arthritis of the hip. When the hip is worn down, you see a picture on the left here shows a normal hip. That cartilage there, that blue cartilage is frictionless, provides this smooth ball-bearing joint that we can walk on and move around on. Arthritis is the wearing down of the cartilage. That's really what it means. Patients ask all the time, how can you tell there's arthritis in there? And it's the loss of the cartilage. So on the right, you see the picture, that cartilage is gone. When that happens, it creates an inflammatory response in the joint that creates bone spurs, osteophytes, and cysts inside the bone that develop. And so this is all kind of a painful joint here. So when a hip hits that point, the only definitive treatment is a hip replacement. You can go to the next slide. So on X-ray here, what a hip looks like. On the left, we've got a very normal looking hip, a ball with that stripe of cartilage there, all well maintained. In the middle, we see an X-ray of a arthritic hip with bone-on-bone arthritis. You see that the bones are touching there. There's no cartilage left between them. And then you see those kind of bubbles in the bone. Those are the cysts that have developed in this patient. So this would be a very painful hip. And then on the right, we've got a picture of a replaced hip where the bright white's going to represent metal, and we can see the parts of the hip replacement. So on the next slide here, we'll jump into the parts that make up a hip replacement just briefly. On the socket, we put a metal back cup that goes into the native socket. And inside of that, a fancy plastic liner called polyethylene locks into that. And then on the femur side, on the leg side, we hammer in this stem into the bone, and that fits in there very tightly with what we call a press fit. And then your bone will physically grow onto these metal parts over the course of about 6 weeks. Initially, they're just held in place by virtue of being in there very tightly with that press fit. Some patients need cement. That's a different story, but the average patient in America gets a press fit total hip. And then the last part there, the ball that actually goes on the stem in modern hip replacements is actually a fancy ceramic, and it is pink. Pretty much the same company makes all of them, and that's a very hard ceramic. So metal, plastic, and ceramic are kind of the three parts there. So moving on to the knee, arthritis of the knee, same thing. A normal looking knee has good, healthy cartilage, devoid of any defects. It's smooth and it's frictionless. It allows easy rotation to walk on. The arthritic joint is one that the cartilage is worn down, and that can be worn down in small areas or in large areas. And when that cartilage is gone, there's no putting it back. And so that's what we refer to as bone on bone, because the bone has lost its protective cushion of cartilage to prevent it from rubbing against each other. In terms of X-ray for knee replacement and knee arthritis, you can go to the next slide, Margaret. The normal appearing knee is here on the left, and we can see there's a nice space between those bones, the femur and the tibia. That represents the cartilage. Cartilage doesn't show up on x-ray. In the middle here, we see a knee that is bone on bone. That cartilage space is gone, and so on x-ray, look, the bones are touching. And that's when, at that point, it's the only way to salvage the knee definitively is a knee replacement if the patient's symptomatic enough. And then on the right, we have a picture of a replaced knee. The bright white here is the metal, and then the space between it represents that plastic liner. And so on the next slide here, we'll see kind of the parts of a knee replacement. Now, the knee replacement really is more of a resurfacing procedure. We're not taking in block. We're not going in and cutting out, massive portions of bone. Really, we take about 8 to 10 millimeters of bone off of both the femur and the tibia. And on the femur, we're going to make 5 cuts and kind of square off the bone and put a cap on it. Looks like a crown on a tooth. On the tibia, we make a relatively flat cut, put a piece of metal onto that, and a plastic liner between there. And so kind of that's the nuts and bolts of what we're actually doing in the surgeries. And so, at this point, I kind of want to jump off into the evolution of how we get from the skin down to the joint, down to the hip or the knee to do that surgery, and how that process has changed over time. This guy here on the right is John Charnley. He's the father of hip replacement. And so he was, in the early days of this, the approach he utilized was one called a trans-trochanteric approach, meaning he didn't want to cut the muscle because he knew there's problems with doing that, and the hip's a deep joint to get to. So he would go in and we would cut that bone of the greater trochanter on the side of the femur. They're depicted on the left. And it has we leave the muscle attachments intact, move that piece as a unit out of the way, do the hip replacement, and then bring it back over at the end. And you can see in the middle, here's a picture of a Charnley hip, and you notice all this wiring on the outside. He has to wire that bone back into place because this is a small piece that's hard to hold with plates and screws. So we put wires in there to hold that down so that it could heal. Charnley had great results, and he was a big innovator for hip replacement. But the problem with doing an approach like this is we absolutely have to have that bone heal in the correct spot to have a good outcome here. And it takes bones about 6 to 8 weeks to heal. So, back in these days, patients stay in the hospital for weeks and were very limited in their mobility early on because if the muscles, especially the ones on the top that are attached, the abductors, the glute medius and glute minimus, are very involved in walking. And so if that piece displaces and goes up, muscles pull them up north towards the head, then this patient's going to have trouble walking, going to have trouble with instability, meaning the hip can dislocate. Our hip is there's no locked in physical linkage between the ball and the socket. The tension of the soft tissues is keeping them together. And so if that repair fails, this patient, could have issues. And so moving on to the next approach that kind of came after the trans-trochanteric, we had the direct lateral approach. Now, this was a workhorse for hip replacement in the United States for decades. Rather than cut the bone, again, the incision was here on the side, but rather than cut the bone, we would go in and those abductor muscles that I talked about, we'd take down part of them. Or initially people would take down the whole thing. Then they would take kind of the anterior third is probably the most common way. You make the cut along where these red lines depict and then completely detach them and take them off of the bone. Then do the hip replacement and then sew them back into the bone there, kind of through bone tunnels and kind of sewing them to the tendon you left behind. Again, this is a workhorse approach. It's a good approach to the hip. It provides excellent stability, very low chance of the hip dislocating. But post-operatively, when patients go to walk, that repaired muscle, because it was cut, is pulling on that repair. And so patients tend to have weakness in their abductors when they walk for a while. And so if you've ever seen people they get that what we call a Trendelenburg gait, where they kind of waddle back and forth like a penguin, because these muscles can't keep their pelvis level. And the abductor strength will recover, but if that repair does fail, they have a big problem again for life, because once those muscles have atrophied, you can't really bring them back down and repair them. And so that was the direct lateral approach. It's an approach that I did a lot of in training. Said it's a good approach, has good function, but it does have its downsides. And moving on to the next wave where we move from there, the posterior approach kind of replaced the lateral as kind of the predominant approach in the United States. And in this, we kind of moved our incision slightly more posterior, kind of going through the buttock. This picture on the left depicts it. Basically, we're cutting right through the gluteus maximus, the largest of our buttock muscles. We go right between it and go through that muscle to get access to the deeper parts. Once we're down there to the deeper parts, you see this picture in the middle. There's a series of 4 muscles. There are 3 of them are small and one bigger one a little more distally, that we go in and we physically cut off the back side of the femur and reflect them out of the way to get access to the hip joint. Do the hip replacement. At the end, we do repair them back to where they go. But again, these are cut muscles. And so the posterior approach is, again, a great workhorse approach. It's something I still occasionally employ in my practice, mostly in revision setting because it provide great exposure. And it's a good way to do a hip replacement. One downside to it, though, is it does have a higher rate of instability or dislocation. The ball in a hip replacement can dislocate from the socket. It can come out. And we know across the literature, the rates of instability or dislocation are higher with the posterior approach. And so you see on the right here, these are hip precautions, all these things you tell you that you can't do because of the risk of the ball coming out. Now, some of that's going to be due to the fact that what we do in life, sitting, squatting down, kneeling down, those are things that stress the posterior aspect of the hip more and make the hip more likely to come out that way than to the front. But some of it is also due to the inherent instability created by cutting those muscles along the backside. And again, those muscles have to heal. And so in that early recovery, when you go to fire your glute max or the short external rotators, you're going to feel that pain and until that repair is really well healed. So it's a little slower recovery and needing assistive devices. So that kind of brings us to the approach I want to talk most about, which is the direct anterior approach. This is a completely muscle sparing approach. No muscle or tendon is cut. And instead of going from the side, we've now moved our incision to the front, and we kind of go down between the muscles. You can see this red line here in the middle depicts, our path. We go down between the tensor fasciae lata and the rectus. And so we get down to the hip and we do our surgery, and then we just allow everything to just fold back over the top. The direct anterior approach has, again, no muscles cut, no tendons cut, and across the literature has been shown consistently to have a faster recovery in terms of less time on an assistive device, being a walker or cane. How much less time that is, it kind of depends on the study you look at, but usually it's at least a couple of days, if not a week or two, depending on the study. But again, anecdotally, these patients recover faster because they're not needing the muscle to heal from being cut. And so they can use those muscles much more quickly. And then the other benefit of a direct anterior approach is that it is an anterior approach and it has a low dislocation rate. Again, what you look at nationwide, less than 1% of hips will dislocate when done from the front. So this is really, we've gone since the days of Charnley from a very slow recovery to a complete muscle sparing, whereas patients used to be in the hospital for weeks. The average patient nowadays, if they're healthy enough, can have surgery at 7:30 in the morning and be home by lunchtime and be off a walker within, it is 3 to 5 days. And so we've really kind of helped by changing our approach to surgery and kind of respecting soft tissue, we've expedited the recovery there. So let's move on to the knee. So surely we've kind of evolved our approaches over the last 70 years, 80 years with knee replacement like we have with hip, right? Well, it's not exactly what you'd think. So the workhorse approach for a knee replacement since its inception has been the medial parapatellar approach. This is, the vast majority, upwards of 95% of knee replacements have all been done via this approach. What this approach entails is you see that blue line there. We go in, if we start down at the bottom of the picture, we come up along, that's the patellar tendon around the kneecap, and then we go and cut the quadriceps tendon. And we cut it in line with its fibers so that we can repair it back, but we cut that tendon. What that does is divides the quadriceps muscle. The muscle on the side with the circle is called the vastus medialis. It's the second biggest of the quadriceps muscles. And so we are dividing it from the rest of the quadriceps, moving it out of the way, doing the surgery, and then we have to close it back over. And so on the next slide here, we can see that when we repaired that, the red line here representing the repair, there are forces by these arrows kind of show you that when you go to flex your knee or fire your quad muscle, you got the vastus medialis pulling this way and the lateralis and the rectus femoris pulling that way. And you're going to have this ripping sensation because there's stress across that repair. And this is with walking, with bending, all the important things we got to do. And so that's going to create that ripping sensation that hurts more in that early postoperative period. You can't move that knee without feeling that tension across that muscle that was cut. And again, the VMO is the second strongest of the quad muscles. And so you have obligate quadriceps weakness when you cut that, when you detach that muscle from the rest of its friends. And so if we can leave that intact, we can decrease strength. So again, I said the majority of knees have been done via that approach. That kind of leaves us to what other approaches are there. And this is where we get into the muscle sparing Subvastus approach. It's the only approach to the knee that is completely muscle and tendon sparing. And so on the next slide here, we can see what we do. And so again, on the picture on the left, let's follow the blue line. We come up from the bottom there along that patellar tendon to the kneecap. But then rather than come up and cut the muscle, we're going to swing around the muscle. Swing and go up and come in from the side, leave that muscle attached to the quadriceps tendon, and move the whole thing as a unit out of the way. When we do that, now we can see the knee, we can do the surgery, and then we just move the muscle back over. And so it allows us to not have to cut the quadriceps, not have to divide it. There's no repair that needs to take place at the end of the procedure. And so go to the next slide here. And that's going to have, less pain with bending their knees, with going upstairs. Anytime that quad has to fire, again, you're not going to get the pulling of the muscle in different directions. And then with that preserved strength of not cutting the quad, we can have less time on a cane or a walker. And then again, that's something that is borne out in multiple studies showing less time needing that cane or walker to get around. And that leads to a better sense of independence and sense of recovery for a patient. A couple of days or a week faster may not seem that much to, me as a surgeon who just cares about the final outcome, but you can have a good final outcome, regardless if it's muscle sparing or not. But to the patient, those couple of days or week can make a big difference in terms of their pain and their quality of life. They're the ones going through it. And so I think it's something that it makes sense to people hey, if we don't cut this muscle, can I have the best chance at a fast recovery? And it's certainly definitely something I've seen in my practice. So you can go to the next slide here. And so to kind of illustrate this, I've got a little series of videos here. These are all patients of mine with knee replacements. They are all 2 weeks out from surgery at their 2-week post-op visit with me. All had total knee replacements, Subvastus approach. And I'm going to kind of show you how they're getting around. There'll be some talking about their experience so far and their walking, and just kind of shows you what's possible. So we got this kind of, video here, and just as an example.
So just to showcase the power of the muscle sparing Subvastus approach, got a patient 2 weeks test post knee replacement. He's doing great. Go ahead and show up your motion there if you would. So kicking all the way out. Great quad control, much stronger. How long were you on the cane or a walker, would you say?
I was on a walker for like 3 days.
3 days?
All right, so here he is walking 2 weeks after knee replacement. No cane, no walker, very normal gait. So he's making it look like nothing at all.
So 2 weeks in the books. How you doing?
I'm doing great. Yeah, out working, driving after 7 days, and showing property within the first 10 weeks.
Yes,
I met first PT yesterday.
you're a realtor showing houses 6 days after surgery. So no cane, no walker. How long were you on that?
I never used the cane or the walker except to get in the house.
Okay.
First day.
First day. And we did our surgery at our Westchester location.
Yes.
You went home same early night.
By 12:30, live 90 miles from there. This has been like a piece of cake to what I was expecting. I really thought I was going to be laid up forever, but it was like the end of the first week. I was up and walking around the house and not using my walker.
How long were you on a walker after surgery?
I was only on for about 2 to 3 days, and then I'd use it at night just in case, it was dark, so I wouldn't fall over. To go beyond that, I skipped right past the cane and was walking about 3 days out.
Great.
Here we are 2 weeks out, total knee replacement. You can come on back this way. So yeah, he's got a very normal gait, doing fantastic. All right, so here she is 2 weeks after knee replacement, walking very well. You can come on back this way. Look at that pivot right there. 2 weeks out, doing great.
You know, she'd had her other knee done via traditional neo-parapatellar approach. And so you're 2 weeks in the books. Tell me, how's it been compared to two?
Just being out 2.5 weeks, I can pretty much do anything I want. I can bend it this far. I can strain it that far. I'm not taking any pain medications anymore. I haven't probably for about a week. And the swelling goes down each day. It gets smaller and smaller. And I can remember 3 years ago when I had this done, I was 4 weeks out and I couldn't really move it anymore, or still. So it's a totally big difference.
That's great. So just kind of find just faster recovery.
Yes.
Said you're actually already driving.
So many properties I have.
All right, so I'm here with a patient who we did a total knee replacement today with at 82 years old via muscle-sparing subvastus approach with Mako. And he's dressed, ready to go home. Kick that leg out there, bring it all the way up there, bend it back for me. Bend it back easily to 90 there until he's hitting the chair. So he passed all his therapy. He's just showing off. But everything went well and he's ready to get out of here today. So again, that quad control with the muscle sparing approach.
Yeah, and compared to the left knee surgery I had about 15 years ago, it is night and day difference between the two. Took me about 2 months with a cane here and probably 5 days with crutches and canes. Other than that, I've been on my own going up and down stairs and walking.
And then range of motion wise, kick that out for me. So he's all the way straight. And then bend wise with therapy, he's back to about 120 with therapy. And really just has already started work on strengthening at 2 weeks, which is really impressive. So
I was dreading having this one done after this experience, and I recommend it to anyone.
Margaret, you can go to the next slide there. So obviously those are patients who've all done very well. I think anytime you're seeing patient testimonial videos, it's important to realize that, we're probably picking the patients who are happiest, but it also shows you what's possible when we treat the soft tissues with respect. So that in terms of muscle sparing, direct anterior hip replacement or subvastus knee replacement, I think that, the mantra of minimizing the soft tissue trauma to maximize the recovery process is really important here. It's not just a bony procedure. We have to respect those soft tissues, not do any more damage than we have to get the job done. I hope today I kind of show the evolution of improving our techniques over time. We're looking forward, we're trying to get better, trying to make this as smooth as recovery as possible. And it's also important that we keep in mind that not every patient recovery is going to be a breeze. But by doing things in a more friendly manner to the knee or the hip, we can give them the best chance at a home run recovery where they, and I think not cutting the muscle is a big portion of that. And it just kind of goes into the evolution of hip and knee replacement combined with better technologies, robotics and better implants to try to really make joint replacement just something that's never been before and a faster recovery with better outcomes. So with that being said, I think we're going to switch over to the question and answer section of this. And I'll turn it back over to Margaret.
Thank you so much, Dr. Stewart. We will be answering questions that were submitted earlier and questions submitted live. So if you are watching this currently on Facebook, you may go ahead and submit a question in the comments. We will answer as many questions as we can, but not all questions will be able to be answered. Our first question is, what's the recovery time for a total knee replacement? How long will you be out of work?
So that's $1 million question, recovery timeline for knee replacement. I think there's different phases of recovery. You have the early post-op recovery, not hurting as bad all the time, able to get around independently and kind of function about life. I think we can generally accomplish those things in the first, 2 weeks. Patients are getting out of the house more, that kind of stuff. I tell everybody, even doing it muscle sparing, to expect that first week to be miserable. You kind of wonder why you did it. It hurts. I am cutting you open and taking a saw to your bones. longer recovery is all about goals and expectations. I think most of my patients kind of get to, about 4 to 6 week mark out and about in the community, doing things, going to the grocery store, going to church. They get tired easily, get fatigued, still got to come in and ice the knee. They're definitely not 100% at that point. Even 2 months out, 3 months out, you're doing more. But I would say you're going to continue to make progress through the first year. I think my tennis players are usually telling me they're playing tennis around the 4-month mark, something like that. Maybe a little earlier, maybe a little later. Golfers around the 6 week to 8 week mark are kind of in the, starting to get the idea to go do some short game stuff. But again, 18 holes walking, that's going to take you longer than going to hit some driving range. So I think full recovery is a matter of expectations and goals. And then time out of work is highly job dependent. I have patients who, if you got a desk job, I've had patients be back at work in 2 weeks. But if you're a construction guy, we're doing hard manual labor, you're going to be out a while. The knee is going to have to recover and get to that strength point. So I think that's a very individualized answer.
Thank you. Our next question is, are there any contraindications to performing the Subvastus approach?
So there are patients who are not ideal candidates for it. In my practice, since I made the change, I've done several hundred of these Subvastus. I've done 2 patients not via Subvastus approach in that time. Both patients had very restricted. I did one last week, actually, very restricted motion. I'm talking about this patient only had about 10 degrees of pre-op range of motion. Very bad knee, not your normal person walking around in terms of their motion. So that's somebody who, a really stiff knee, it's not the best option for you because bad things could happen. We could avulse the patellar tendon. I got to be able to get the surgery done. If your knee is too stiff ahead of time, that can be a contraindication to it. Otherwise, it's going to come down to surgeon experience with it, surgeon preference, and so some surgeons who do it but maybe don't do it as often, or everybody may have a more narrow window of who they'll do it on. But the biggest thing is extreme post-op stiffness, I would say, or pre-op stiffness.
Thank you. What is the advantage of using robotics?
So I am a very big believer in robotics. I use the Mako robot on all my knee replacements. I think that by using a robot, we can be more accurate, customize the cuts, and really give that knee kind of what it needs and not kind of take a one-size-fits-all approach, which I would argue that the traditional method of doing a knee replacement, a lot of the cuts are based off of averages, the average amount of valgus in a distal femur, the average slope, things like that. And so the robotic system I use is a CT-based one, so it's accurate to the 0.1 millimeter degree. We don't have that kind of accuracy with traditional manual instrumentation. And so the advantage of robotics is more accuracy, more patient-specific cuts and implementation of a surgical plan. And then also robotics allow us to kind of predict how a knee is going to behave before we've even cut bone. And that's a big talk, that is in and of itself, but we can use these tools to have more information. The more information we have, the better I think we are at everything we can do. So I think I'm a big believer in robotics. It's certainly a lot of surgeons aren't, but I'm kind of a forward thinker in that regard.
Thank you. How long does it take to get full strength back into your leg muscle after a hip replacement?
I think there's a difference between full strength and perceptible strength. For instance, and I use this example in clinic all the time, professional athletes, when they have an ACL tear and an ACL reconstruction, these guys are doing professional rehab every day, lifting weights, and they're on these machines measuring their strength. We know that ACL knees, even in a pro football player, their leg is still weak, about 8 months after surgery, even 9 months after surgery. And those are guys who are working out all day, every day for their job. So I know that the hip or the knee stays weak for several months, up to, I'd say, the first year after surgery. The question is what is perceptible in terms of the amount of weakness. Most of the hips feel very back to themselves strength-wise by, I'd say, the 2 to 3 month mark. The knee, as you demand more from it, you'll see it takes a little longer to get there. Depends on your goals. If you're a tennis player, it's going to take longer than if you just want to walk the dog.
Thank you, Dr. Stewart. That is all the time we have for questions today. Would you like to close?
I'd just like to thank everybody for tuning in today. I think that it's a exciting time. We're kind of pushing the ball forward, so to speak, in joint replacement. We're doing a great job with that. I think these talks are nice, not just a joint replacement, just giving patients more information. We want you to be informed and educated on your decisions. It's your health, your knees, your hips, your backs, your shoulders. So thanks again for tuning in, and come check us out at OrthoVirginia.